So whole gland ablation, and this is in the subtitle section of the meeting of controversies in focal therapy. I'm not sure how controversial it is, and as I was putting this all together, I got less convinced of how controversial it is. Interestingly, Dr. Katz gave a really nice presentation on this yesterday in the balloon debate, which I think really summarized it nicely. So I'm not really going to spend a lot of time on it. I'll just kind of cut to the chase of some of the concepts that I think the Focal Therapy Society has put out recently that really summarize this. But the concept that I often talked about this with patients comes up when we have a focal unilateral tumor, as Abhi just mentioned, and we're talking about treating it, but we know there's some small disease outside, MR invisible, in the contralateral prostate that we picked up. And I've tried to reassure them that we'll treat that with active surveillance, but we're going to go treat the other side with an ablation. And they're always like, well, why don't we just hit the other side too? And I'm always of the mindset to tell them, look, that we don't have to do that. And I use the phrase, what I say to them is, well, when we start to do that, we're starting to approach whole gland treatment, and I don't see an oncologic benefit for whole gland ablation compared to our standard whole gland treatments, and therefore the real advantage of the partial gland ablation, you're eroding it. And I'm not entirely certain that that's 100% true, but it's at least the rationale that I use. After going through some of the data that I'll present here, maybe that's not as accurate as I'd like it to be. So I'll just skip through this so everybody knows about that. This is from PROTECT, though. This I think is helpful, right? What we learned from PROTECT, and we saw with the PACE-A trial that Dr. Song presented, is the quality of life impacts are real. We may not have mortality, but we are really impacting quality of life with these whole gland treatments. And so this is where we really want to work on improving our treatments. And, sexual quality of life and urinary quality of life are critically important. And can whole gland ablation do better than these two treatments while still working in the space of the focal therapy space? And I think there is potential for that. And certainly over time, the trends in the use of active surveillance have increased, but I think this will also, impact how we use ablations. And so where can a whole gland ablation fit into this concept? Can it offer similar cancer control rates? Can it mitigate the side effects that our standard whole gland treatments offer, whether it's prostatectomy or radiotherapy? So what are the considerations for when you might put whole gland ablation at the top of the list? Well, when you have a patient who's got a contraindication for surgery, if they've had radiation to the pelvis before, or in a Crohn's patient who's had multiple revisions of a J pouch, and the pelvis is the last place you want to do anything surgically or with radiation treatments. Those are some serious considerations where if you had another method that you could treat the whole gland, and those are not contraindications from surgery such as the patient couldn't tolerate surgery. I think in that setting, you need to question whether you need to treat the prostate cancer, but these are people who you would ordinarily want to treat. Prior pelvic radiation with rectal cancer, and if it was distant, for example, they don't have any records, and so the radiotherapist doesn't even know where the exact radiation field was. And Dr. Katz mentioned some of these yesterday in the debate, and I think that's interesting. And then as Abhi alluded to, it's the patient preference where they're like, I don't want to have radiation, I don't want to have prostatectomy, how come you can't just ablate the whole gland? Well, you have to have an answer for that when that comes up, and you have to have a rationale. And so the Focal Therapy Society put this out. A lot of us in the room are authors on this, and it's a very nice systematic review. I'm going to just go through some of the highlights because Dr. Katz highlighted a lot of this yesterday as well. 29 studies, 14 of which were cryoablation, 15 were HIFU. This is important as well. Not all of the focal therapy technologies that we've talked about this weekend are capable of doing whole gland readily. But cryo and HIFU primarily have some data behind it, but some of the technologies are actually quite focal, and doing and achieving a whole gland ablation with these technologies would be a bit challenging. So the median sample size the study incorporated was about 261, and they had about 72 months of follow-up. Most of these are retrospective studies. And about 45% of the cohorts that were evaluated were in the intermediate risk D'Amico criteria space, so it's relevant to what we're doing. And there was about 12% that were actually higher risk patients. Most of those were in the cryo space. So oncologic outcomes is a little bit of a busy slide, and I'll get through this in a little bit of more detail. And they broke down data on 5-year and 10-year follow-ups. And overall, they used a number of metrics to assess for the oncologic effectiveness. Biochemical recurrence-free rates we'll start with. The problem with this is there's no standard definition. So they applied the Phoenix criteria, or they applied the Stuttgart criteria, which specifically for whole gland HIFU. And then there was even a few studies that they applied their own de novo criteria. And you can see that the biochemical recurrence-free survival 5 years in these studies, conglomerates, 50% at 5 years for the high risk, but for an intermediate risk, it was 60, 78%. Look, what can you draw from that? Depends on the ages of the patient, but this might be reasonable. And I'll come to the end, at the end, show how that might compare to some of the other whole gland treatment. Recurrence-free survival, this is often, you would hope, based on biopsy. A lot of these studies were in the non-MRI era, so it's very difficult to extrapolate this. But again, as the risk level goes up, the recurrence-free survivals drop. But there is a single series of HIFU data here that goes out to 15 years, and you can see that they had pretty good outcomes on that 15-year recurrence-free survival of whole gland HIFU. That's pretty good. 82% in their low and 73% in their intermediates. 47 at the high is very good. So look, that goes to show if you really ablate the whole gland, I think maybe you are achieving comparable disease control. Not much biopsy data though, right? And it does beg the question of what are you actually going to biopsy in many of these scenarios. They reported broad ranges of data here, and positive biopsy rates were as high as 60% in some of the studies. I can't really draw much from that. It's very poorly defined. How about developing metastases? At 15 years, again, some of the data goes out, and a high-risk D'Amico of 58% metastasis-free survival, so that's pretty good as well, I would say overall. Cancer-specific survival similarly looked pretty good even out to 15 years. And overall survival, this goes into, a lot of these men may die from other causes, but overall the cohorts all looked pretty much, the theme keeps repeating. These aren't, they're not terrible numbers. So what are we doing in terms of mitigating the side effects? Well, the overall PAD-free rate was 96% with whole gland ablations. It was a little bit better in the cryo, but they're comparable. There was some decrease in IPSS scores in a study that reported that with whole gland HIFU. There were no grade 3-4 urinary incontinence in one cryo series, and there was some transient incontinence noted in one HIFU cohort at 3 months, but it resolved. So look, that looks pretty good from the voiding. How about erectile dysfunction? Unassisted erectile function. Overall, this is where you're going to take a hit mostly, right? So 37%. That's pretty pronounced. Assisted erectile function, anywhere from 25 to 70%, and there was up to 2/3 of some of the cohorts that were reporting use of PDE5 inhibitors. Comparable to a radical prostatectomy series, probably not too far off, honestly. How about complications? Well, urethral stricture, they had 9 studies that reported on this. They were primarily in the HIFU space, and it was about a 10-11%. 5% in the cryo versus 12% with HIFU. Maybe the urethral warming catheter is a nice way to mitigate some of that risk. Urinary retention, about equal in the two technologies, and it was 10% overall. 14% with the HIFU is a little bit higher there. And I know historically when you do a whole gland HIFU, a suprapubic tube was employed in a lot of these men because there'd be a prolonged sloughing of the urethra, and I think that's what you're seeing with this patient population. And certainly when I've done partial gland ablations with HIFU and cryo, I've very close to the urethra, I've seen some of that sloughing and seen some more prolonged of urinary retention or catheter requirements. Urinary tract infections are reported. What's interesting here is, You'll see this, I think, even with partial gland ablation. Sometimes you get an orchitis on the ipsilateral to the ablation zone, congestion. I'm not sure what the exact mechanism is always, but they've noted in 4 studies what they deemed severe UTIs. I don't know what the definition of a severe UTI is compared to a UTI, but they didn't define that, but it was higher in the HIFU cohort. So I'm not sure if that's epididymal orchitis or not. And the dreaded rectourethral fistula. So this is actually not looking too bad. It was less than 1% in the overall reporting. They had one, again, they like to apply the severe nomenclature. I don't know how severe, how you grade rectourethral fistulas after HIFU, but they had one event of that in that one study. Well, so it's not a glaring red flag. So that's good. So additional morbidities that were commented on, urethral sloughing and perineal pain. I was a little confused by there could be an 8% rate of HIFU perineal pain, which I understand with the transperineal approach with cryo, but with the transrectal HIFU, I was a little surprised to see that. I don't think I've ever seen that in my clinical experience. So this is sort of the most important component, right? What are the comparative 10-year numbers when we take into consideration our other standard whole gland treatments? So radical prostatectomy, radiation, biochemical recurrence-free survival. It's not a standard definition, but they look pretty good here, right? Cancer-specific survival from this meta-analysis, not too far off. Same thing down the line. I mean, overall, not a big red flag again. So, and over about 22% of this whole gland ablation cohort was high risk, and they were older by and large. As you might imagine, a lot of these men probably weren't great surgical candidates, and so they got selected towards whole gland ablation originally. So what do we know from PROTECT data? The disease-specific survival is a little bit better than this, 99.5%. It was 96% for this whole gland, and again, I think it's due to some higher risk patients in this whole gland meta-analysis. And there are randomized controlled trial for cryo versus radiation, and I think these are really compelling because they did show at a 3-year biopsy endpoint a significantly lower rate of cancer detection on biopsy with the whole gland cryos, and that was 8% versus 29%. I think that right there is also very compelling, that this concept is not so controversial. I mean, I think it's overall here in our echo chamber, it's not so controversial, but the data here isn't so bad. Pad-free and erectile function, when you compare prostatectomy, it looks like we do better on the side effect profile overall, especially on the continence side. Erectile function, maybe not so much. So in summary, we have over 25 years of data with these whole gland treatment approaches. There's not much data on some of the newer energy, and I think if you have a scenario, especially some of those scenarios I highlighted earlier, that you can't use the whole gland treatments and you know the man needs a whole gland treatment and you can't give a radical prostatectomy or radiation, this might be a good option. And then when you consider doing a partial gland ablation, and we talk about margins and we talk about making sure you have a confluent treatment volume, we should be trying to achieve, first and foremost, confluent control of the cancer that we know about. That's significant. Infield failure rate right now is our biggest enemy. So this says to me that if you expand your ablation zone to some degree to make sure that you're getting that infield treatment as effectively as possible, you're not going to really make a huge compromise on all the other aspects that we're trying to preserve. It's very encouraging that centimeter margin, and we've heard a lot about that today, and how to plan for this. We don't have a great grasp on it. Bigger is probably better right now, and we can get fancier in time, but for me, I really feel that we can't afford infield failure rates at a high rate right now. We really need to work on making sure we're getting this disease with the ablation to destroy that disease reliably. We'll figure out who's going to develop the secondary tumors later on in a different question, but right now that's really where I think our focus should be, and this whole gland data really supports the concept that we're not going to just destroy the quality of life advantage by increasing our treatment margins and our treatment volumes. Thanks.
This is a lecture that both myself and Abhi kind of like argue about this a lot. And so we said, you know what, we're going to assign a talk to Jim and he'll figure it out. Okay. So thank you, Jim. But really, I think he's kind of convinced me that maybe I underutilize whole gland ablation in my practice. And, beyond that one study that you showed at the end, the radiation study, you kind of maybe intentionally or not, created a relatively reasonable argument for whole gland ablation, especially in the context of, Dr. Feinberg's prior discussion. So I guess that really leads to my question, like, how do you utilize whole gland ablation in your practice? And like, oftentimes the decision is, whole gland ablation versus radiation, really. And so what is the perfect whole gland ablation candidate? Who is a reasonable that you would actually offer it to over other radical treatment options?
I come to any ablative approach primarily on an image-based basis. So if it's an index lesion paradigm, I'm going to try to use a partial gland ablation. I don't put this high on the list unless for some reason they're contraindicated for a whole gland treatment option with one of our standard approaches. Now, that being said, in the salvage setting, I find that there's probably a greater rationale for a whole gland salvage ablation in some scenarios, because I feel that even with a salvage ablation, you have around a 50% success rate. If you address that, some of those are local recurrences in the gland, and maybe a whole gland salvage ablation would be higher on my list of possibilities. Again, the rationale is if I can offer them a whole gland standard of care option, such as prostatectomy or radiation, then I think that's going to be where I will go first. Now, to offer whole gland ablation above that, even with this meta-analysis data, it's encouraging. I still don't use that rationale as an oncologic strategy.
I offer whole gland ablation more liberally in elderly patients who are not surgical candidates, and either they're contraindicated to get radiation or there's social reasons they can't get radiation. They cannot come 28 times to the hospital to get radiation treatment. However, one thing I always wonder, these patients do really well. Like, they don't have erectile function, so you're not preserving them, but they're not incontinent, and their PS is low. Then I'm not getting their MRIs, and I'm not doing their biopsies. And then I wonder, do I really should do focal in this setting? Like, are we doing focal only for the database purposes? These patients are never gonna get surgery, so you're not burning that bridge. They can always get radiation down the line. Why not do whole gland ablation in a 75-year-old who has a big tumor on one side and focus your attention on that side and still ablate the other side so that we don't have to get an MRI and a PSA? Are we hurting them when the morbidity is so low?
It's a good space for a trial, Avi. I think it's a good space.
Yeah, thanks. That was great. I mean, I would just posit, I mean, this is for obviously technologies that have 15 years of data for, and so, but TULSA is able to do a whole gland treatment or with particular sparing of the nerve bundles to kind of mitigate some of those issues that you see when you need to do bilateral treatment and you want to have more precise coverage and sparing of the nerve tissue. You can get anterior, you can get posterior. Works well for lesions that are in that sort of 5 o'clock position, and then 10 o'clock. You can really get good coverage of both of those. It'll be interesting to see the long-term oncologic data, but I think we should not be the primary functional areas, as we've been talking about this whole conference, are the nerve bundles for people who are trying to preserve erectile function for and along the urethra. And if you have good control, we shouldn't be afraid, I think, of treating a lot of the prostate tissue if we're able to preserve those functional areas. I welcome discussion of that. I mean, Avi, your point that, did you just leave? Well, yeah. His point that, why treat the contralateral side if we only have cancer on one side? I think that could be pushing it. I mean, unless you can see some improvement in their IPSS scores, but that would be an interesting thing to see. What are we losing by treating more volume?
Right, and that's the rationale for the PROCEPT trial, the WATER 4. I don't know if you guys are too familiar with, but that's the idea. They're going to do subtotal aquablation and randomized to prostatectomy. That rationale is exactly what they're utilizing. Is the morbidity is low if we take it out from the inside. We'll preserve all the capsule, we'll preserve the nerves, and they'll be continent, and we'll see how that looks. And this type of data supports that concept. But it's a trial, and I think it's worthwhile.